Okay, we can get started now.
Awesome, great. Hi, everybody. I'm Gurtej. I'm on Dr. Abramov service currently, about halfway through. I'll be doing my quick topic about sexual dysfunctions in male patients who've had spinal cord injuries. So first and foremost, just some numbers about spinal cord injuries. In the U.S. specifically, there's about 17,500 cases, about newly a year. Prevalence is usually about 288,000, and males, majority-wise, tend to be more affected than females. In particular, the average age of those who obtain a spinal cord injury is about 40. And, given in this topic of what we're talking about, 40 years, around 40, people are still trying to have families, form relationships. So it kind of fits in with the whole topic of the complexities in terms from a social aspect of reproduction and sexual dysfunction that can affect people's lives. And also the most common cause still at this time is motor vehicle accidents and falls, and C5 tends to be one of the most common areas for a spinal cord injury to occur. The picture on the right-hand side, especially, just kind of can demonstrate right here where you can see a little bit of displacement of the spinal cord around C5 actually. You can also see some signals as well, just indicating that there is spinal cord injury damage. So in terms of the sexual aspect of it all, there's various different aspects to it. Mainly it involves the parasympathetic as well as the sympathetic nervous systems. In terms of the part of the erection, there are two arcs that are mainly spoken about. One is called the reflexive arc, and the other is a psychogenic. And for the reflexive arc, there are actually two parts, the afferent and the efferent limbs. So specifically for the reflexive arc, it can also be further modulated by the higher brainstem, subcortical, as well as the cortical regions. So for the afferent arcs, it involves the afferent fibers, the somatic afferent fibers that originate from the genitalia area. They travel through the pudendal nerve into the sacral spinal cord. Specifically located into S2, S4. And then in terms of the efferent part of it, which is also still parasympathetic, they originate from the sacral spinal cords and travel to the cauda equina, and then to the S2, S4 nerve roots. And then further down the line, postganglionic parasympathetic fibers then secrete nitric oxide, causing arterial dilation of the corpora cavernosum, as well as causing decrease of venous outflow, thus sustaining an erection. It's also the psychogenic aspect of it is more of a supraspinal process. It also has cortical modulation. And for the bottom part of the ejaculation, that is more of a sympathetic dominant more of physiology. Well, so in regards to like the specifics of the dysfunction, those dysfunction occurs in those with complete or incomplete upper motor neurons or with lower motor neuron spinal cord injuries. In regards to this, there have been shown that for those in the people who have reflexive arcs are kind of intact, those who have complete or incomplete upper motor neuron lesions, but you can also see this reflexive arc still prevalent, about 25% of those with complete lower motor neuron lesions. And this kind of demonstrates the importance of the sacral parasympathetic neurons and the reflexive for the erections I mentioned earlier. There's also, in regards to the psychogenic aspect of erections as well, it can be seen about 50% of patients with incomplete upper motor neurons, as well as 25% of the lower motor neuron lesions. Oddly enough, those who have a complete upper motor neuron lesion very unusually don't actually have any type of erection at all. So with this in mind, there's been various different approaches as to help modulate males who are suffering through the situation. And if I haven't already said it, it is harder for a patient to actually have an erection. It's easier for a spinal cord injury male to have an erection than to ejaculate. So in terms of focusing on the erection part, there are various different modalities that are in place to help augment the situation. The first is obviously the PDE5 inhibitors. This essentially causes smooth muscle relaxation They usually recommend that the medication should be taken about an hour before intercourse to allow for appropriate absorption of the medication. I've also read that there actually also a requirement of sexual stimulation, both physical and mental, to help create excitation and the generation of cyclic GMP. And this is usually a medication that is very successful in patients with upper motor neuron lesions. But obviously, those who are on nitrates, this is something that should be avoided. Another is the bullet, the loaded bullet, which active ingredient is actually prostaglandin E. This medication is placed directly into the urethra. It's absorbed. It causes an intracellular increased levels in cyclic AMP, leading to increased intracellular calcium, thus leading to further muscle relaxation. And you guys can connect the dots from there. There's also the injection too. That injection has multiple vasoactive components. It does have high satisfaction rates, is what I read, but the drop on those who actually continue to use is actually quite high, mainly due to cost, and also just for a desire for a more permanent solution as well. We've also got other types of modulation, such as a vacuum for constriction, allowing for essentially blood to pool to the penis, as well as a transplant pump. But that has a lot of the complications affiliated with it. There's the cost, there's infections, and also just a high failure rate as well. So some other, just not for the second part of it, the ejaculation part. As I mentioned before, it is harder for these patients to actually have an ejaculation and compare it to an erection. So the nerve fiber, and as I mentioned earlier, there's an interplay between the sympathetic and parasympathetic, but the sympathetic overall is the predominant. So for the fibers that are involved with the ejaculation component, mainly originate from the spinal cord of T11 to L2. They travel through the hypogastric plexus, and then they innervate the vas deferens, the seminal vesicles, as well as the ejaculatory ducts. The rate of ejaculation kind of varies in terms of the success rate, all depending on the location of the spinal cord injury as well as the nature of the overall injury itself. But approximately 5 to 15% of men with complete upper motor lesions, as well as 18% with complete lower motor lesions are still able to have ejaculations. The percentage are higher in terms of those who are incomplete, thus essentially getting to the common understandable point that those who have a more incomplete lesion tend to have better outcomes and better success in this area. And once again, there's also different things that we have to help augment this aspect of the deficiency as well, so to speak. You have the penile vibratory devices. These tend to be more easy, safe, and reliable. It's usually applied to the back of the frenulum of the glands for several minutes, and to repeat a couple every 10 minutes or so until the desired outcome is seen. But sometimes those who actually don't really have a result with the vibrator could have another option of the electric stimulation. This is done through placement in the rectum of the patient, and it stimulates the nerves and the smooth muscles of the prostate, as well as the seminal vesicles, as well as the pelvic walls. But as one can imagine, electrical stimulation comes with some of a cost. It's very painful, and it can also, elicit autonomic dysreflexia as well. It's been shown in a couple of articles I read that it's very effective, about a 95% ejaculatory success rate, but because of the downsides of it all, a lot of individuals do not like to pursue this, and usually there has to be a healthcare professional at the site to at least observe it to make sure it's being done appropriately. So other factors to consider, those of men who have a spinal cord injury down the line. What does this mean? It does show that those who have this spinal cord injury have the same amount of, at least in general, the amount of sperm, but it means that overall the quality of the semen is actually decreased compared to the normal population. And there's multifactorial reasons for that. One is the prostatic stasis. Oddly enough, but interesting enough, I guess you could say. Some studies have shown that electric stimulation actually increases the viability of the sperm after 2 to 4 sessions compared to just using the penile vibratory device. Then we also have the hormonal axis. The exact etiology of it all is not known, but it's been shown that testosterone in these patients are decreased. But as to why this is the case, more studies still need to be done. Testicular atrophy is also noted to be seen on biopsies of specifically the seminiferous tubules. But the exact correlation as to why this is the case is, once again, something that needs to be further studied. Patients with spinal cord injuries also have recurrent UTIs that can decrease overall quality, as well as, interesting enough, bladder regimen. They've shown that people who've had intravenous catheterizations actually have more viable semen compared to those with indwelling catheters. So once again, as I mentioned, it's the quality of the semen that is the issue, not really the number. So just some take-home points. Fertility and sexual reproduction is an important aspect of the general population, including those with spinal cord injuries in terms of family, other social spheres. There are multiple treatment options in place to help augment the current dysfunction, but once again, there's nothing that is guaranteed, no positive guarantee there. And in terms of addressing this specifically, multidisciplinary team is somewhat advocated for. PM&R, urologists, psychological therapy, as well as fertility experts are all areas that, especially when it comes to having families and moving down the line, something that should be considered in order to best maximize patients who've had spinal cord injuries to have the most, I guess one could say, normal type of life moving forward. That's all I have. Thank you.
Thank you, Gurtej. Any questions from David, aka the audience?
Hey, yeah. Good job, Gurtej. Nice talk. Had a couple follow-up questions for you or Dr. Abramoff. First, in your research for this, did you come across anything that talked about maybe changes in like sex drive, libido in these patients? You mentioned sort of dysfunction maybe in testosterone production. I'm just thinking that may have an effect on libido. Just wondering if you came across anything like that.
If I'm not mistaken, I think I did come across one of the articles I was reading that there is somewhat of a decreased libido drive. I'm not sure as to like the timeline in terms of how long after the injury and how long does it persist, if not indefinitely though.
So I'm not sure the answer to that. It's a good question, David. In terms of whether libido is changed, I think there's kind of one element is testosterone is decreased in individuals with spinal cord injury. A lot of people with spinal cord injuries, either physiologically or psychologically, are hesitant to get back into sexual relationships, sexual functioning, whether that's, self-consciousness, whether it's just that they don't think they can perform or they had issues when they tried to do it in the past. So there's a lot of people with spinal cord injuries who don't engage in sexual activity. Now, whether that's a libido issue, I don't know how you'd even really measure that. But I think that's, I think there's a lot of things. They're also on drugs, antidepressants, opiates, all things that can affect the sex drive as well. And pain and, all the other things that can kind of apply. I think there's another question kind of in there too, is in terms of kind of sexual enjoyment, the sex, beyond just the mechanics of it, right. Whether you have sensory impairment or, physical impairment. Gurtej, did you read anything about that element?
I did not go that far in deep, no.
So, one question is, are people with spinal cord injury able to like orgasm and, or if they don't feel, why bother, might be the question. So there's a couple things. One, there's still the sense of intimacy, there's pleasing the partner, all those things, play a role. Another element is, there's, besides the kind of cutaneous sensation, sometimes there's autonomic, deep, peripheral, sensation. Not every injury that's complete is truly complete. People with spinal cord injuries have described, different kind of forms of orgasm. That's not, that's changes. There's neuroplasticity involved. So areas that weren't sexual before or not as intensely sexual before, as the brain kind of seeks that sensation, will make other areas more sensitized, whether that's the ear, the neck. A common place that's described as kind of that sensory transition zone is being kind of overly sensualized. And then that usually comes along with imagery, sexual situations, and using those together. Oftentimes patients can still have orgasms and still have very satisfying sexual experiences. So, I think the key thing to kind of advise your patients about is being willing to experiment. So, first experiment by yourself, see what your body can do and what it can't do. And then, being willing to kind of be open with a partner and talk. And a lot of times, patients have reported that in some ways it improves their sexual relationships because they do have those kind of open conversations. Gurtej, did you read about it at all, kind of like, or any thoughts on kind of what somebody should do before they're, start having sex and things like that?
I stuck mainly to the physiology part of it. I didn't really delve in more in terms of like things to. Yeah, sorry.
Yeah, it's okay. So you always want to kind of clear out bowel and bladder beforehand. Do bowel program, do bladder program. Autonomic dysreflexias and skin things are things you have to consider. If somebody does get dysreflexic, you don't want to use nitropase because they just had a PDE5 inhibitor, and you don't want to drop their blood pressure too low. There's all sorts of different equipment besides like the vibrator for ejaculation, which is what product is that, Gurtej, that is recommended?
The specific name of the device, or?
Yeah.
Ooh, specific name, I can't recall. I know there is, starts with letter P, I think, but.
Yeah, it's called a FertiCare device, and it's usually, I believe it's high amplitude, low frequency. Don't quote me on that. But it's been studied and specifically designed for people with spinal cord injury. And there's different techniques such as like the sandwich technique using two, which sometimes helps kind of boost that response. And then there's things like, it's called like the Easy Rider and other equipment that's specifically meant for patients that have incomplete movement to help with sexual activities. Cool, David. What other questions do you have?
Just I guess more so for you, Dr. Abramoff, in your experience. One would be kind of how do you determine when the best time to kind of have this conversation is with a patient, like a new spinal cord injury patient? And then the second question would be like, have you noticed, I know this talk was mainly about sort of sexual dysfunction in males, but in females, do you see any kind of unique issues that they that female spinal cord injury patients have?
So a couple things. When's the best time to have this conversation? I don't, oftentimes, even though people are kind of like saying, am I going to walk again? A lot of times in the back of their mind, they're thinking, am I going to have sex again? Am I going to have relationships? Are people going to love me? What's going to happen with my fiance? So I don't think it's too early ever to really talk about this. Definitely by the time they leave acute rehab, this conversation will be done. You shouldn't make any assumptions based on age, sexuality, things like that. Gender, always have this conversation with everyone. Women's kind of a completely separate topic. For lots and lots of years, the focus up until probably last 10, 20 years was always on like reproduction. And that element is particularly for women, and the kind of the pleasure and the satisfaction element weren't considered quite as much. But I think that's worth having that conversation, having another talk on that in the near future, just to kind of clear with this one. Any other questions, David?
No, I'm good. Good job, Gurtej.
So one clarification point. So men with complete upper motor neuron lesions frequently are able to get erections through the reflexogenic arc. I think the numbers are greater than 90%. But maintaining it and things like that can be challenging. Cialis tends to work a little bit better anecdotally. for some patients than Viagra, so that's always something that you can consider. You mentioned loaded bullet, which isn't a term that I'm familiar with. The more common term is Muse for the alprazolam penile suppository. That doesn't work traditionally as well. And what's the next? And then the next step is like Trimix and other intracavernous injections, which is can be very helpful. Let's see. One thing. Did you read anything, Gurtej, about ejaculation following spinal cord injury in terms of things that might be a little bit different, or how to manage it?
No, I don't. Nothing specific.
How about retrograde ejaculation?
Oh, yeah, I did. Actually, yeah, there's retrograde and antegrade. Sometimes I think it can become retrograde, and if that's the case, I believe there's some intervention that needs to be done.
So retrograde ejaculation is pretty common, particularly when you're using some of these techniques like penile vibratory stimulation and electroejaculation. If you're going to be doing like electroejaculation, a lot of times you'll insert a buffer into the bladder after they've been cathed, and then you can retrieve the semen from the bladder. Semen analysis, if you're going to kind of some of these more intensive steps, it's usually probably a good idea. For somebody who's doing like electroejaculation or is prone to autonomic dysreflexia, oftentimes it's a good idea to pre-treat with like nifedipine or something along those lines, just to try to stay ahead of it. And then, yeah, I think that's it. It's an important topic. It's one that I think, compared to like walking and everything, doesn't get as much attention. But it is a really big deal for a lot of patients.
Thank you.
Anything else you want to add, Gurtej?
No, sir. All I know is there's a lot more aspects to it that I did not consider, that I didn't really think about. But thank you for educating me on it.
No, good job. And we'll post this to the YouTube channel. Thank you, guys.